Dr. Johann Christopher is our next speaker. He's a radiologist at Care Hospital, Hyderabad.
Okay, so today I'll be talking about the role of cardiac MR in diastolic heart failure. And diastolic heart failure is an enigma. There is a search for the elusive substrate. There is no specific drug and there is no specific management, unlike its cousin, heart failure and reduced ejection fraction. However, the Emperor Preserved trial really put things in perspective. And after a series of failures, the DAPA, HF, and the Emperor Reduced, the Emperor Preserved finally found that in patients with EF of more than 40%, which is defined as a preserved ejection fraction, empagliflozin 10 milligrams seems to show up a significant advantage and decrease in cardiovascular mortality. What is diastolic heart failure? And if you look at the pressure loops here, you will see that for the same given volume compared to a normal patient, there is a sudden rise in pressure, and this is accentuated during exercise. And basically, this is a marked increased LV afterload, a decreased LV relaxation, and an increased stiffness. And how do we see it on MR? We have a wonderful tool called ECV, and we find that a ECV which starts increasing over time seems to be the real culprit in this whole diastology. This is an imaging center at Care Hyderabad. I'm a cardiologist working here. Now, cardiac MR in a single examination is able to give us high spatial resolution pictures to address morphology, function, volumetry, and perfusion. It also provides data at the myocardial tissue level, therefore addressing the replacement fibrosis and the interstitial fibrosis, and also the structural changes of the left ventricle, that is the LVH, and the structural changes of the left atrium, LA volumes are suitably addressed. If you look at this, these are the cine images of a patient with diastolic heart failure. These are patients with delayed enhancement showing the scar. These are the black blood images showing the pericardium, and the delayed imaging showing us the inflamed pericardium, as Dr. Parashar showed beautifully about constrictive pericarditis. Now, what are the kinds of patients that we generally include in HFpEF? This is a patient with a subendocardial scar. This is a patient with a subendocardial ischemia, suggesting that there is underlying CAD. And this is a patient with a classic amyloid having the typical bullseye appearance. And this is a patient with hypertrophic cardiomyopathy with a significant septum. And this is a patient with a delayed enhancement of the typical constriction of pericardium. Now, there are mimics. Obviously, there are respiratory mimics, especially PAH and COPD. There are liver and kidney mimics. There are patients with high output states like anemia and extracardiac shunts. And obviously, obesity is always on the. Why do we choose MRI compared to its very, very close compatriots? And that is because it is able to encompass morphology, function, tissue, and metabolism by using a single scan and a single contrast. Well, its most close competitor, and the one that we always look to, is echocardiogram. And echocardiogram, as you know, ticks all the right boxes, but it is in the etiology and the extra cardiac finders that MRI really scores heavily, and therefore it is a second line investigation once the echo has a fair point on that this patient may have a HFpEF. So the technique is complex. There is no preparation. However, there's a lot of positioning, including the ECG signals, non-ferrous leads, breath hold, multiple sequences, which I'm going to talk to you. And then, of course, the gadolinium contrast, which is there in plenty and is not subjected to various problems like the nuclear dyes are. Now, this is a busy slide, but it is basically showing you the MRI toolkit, looking at the localizers, the various sequences, and then the big contrast administration comes in, and we wait for about 10 minutes to do the post-gadolinium sequences. And during this time, we do the volumetry, we do the phase contrast, and we do what is called the T1 post-GAD images. Now, these are the basic facets of what we do on MRI for a diastolic heart failure patient, and we'll be looking at these more closely. The first one, obviously, is ejection fraction, and we know that the whole problem of HFpEF is to prove that the ejection fraction is more than 50, and we also know that the prognosis is sufficiently different if you cross over 5 years. And we also know that MR is clearly the gold standard. You can see these beautiful images from an obese gentleman getting you the ejection fraction, the mass, the diastolic volume, and the stroke volume. And with EI coming to the picture, Dr. Prabhu gave a very good reference. You find that infinite number of sections can be taken, and you get a very good plot for the RV and the LV. And these are super accurate, and more importantly, over a longitudinal period of time, seems to be very accurate in recording the decrease or increase in ejection fraction in these patients. The LV mass also can be calculated by this formula, volume into specific gravity. And even with a varied hypertrophy patterns, as you can see in this patient, the hypertrophy is excellent. The quantification is excellent compared to echo. Moving on to diastology, which was always the realm of echocardiography, we have used a fairly old technology called the phase contrast CMR, which has been around for the last 30 years, to look at velocity, flow, and volume. And by the shift of the moving spins and their phase difference, we are able to calculate the difference in the velocities. So what we look at first is to picture the mitral, the tricuspid flow velocities, and this is what you get at the mitral level. And this is the typical trace that you get out of the transmitral flow, which is similar to that of the echocardiogram. With the advent of 4D technology, we are able to, in one snapshot, get the mitral, the pulmonary veins, all of them, all in one snapshot, and really show the beautiful graphs for the pulmonary and the mitral. And by the same 4D technology, in one snapshot, we're able to get the SVC, the tricuspid filling, the suprahepatic vein filling, the coronary sinus, and the pulmonary artery in a single snapshot, which takes about 5 to 8 seconds. And then we construct a valve map, and you can see the various color coding of the maps, the tricuspid, the mitral, the pulmonary, and the aortic map using the 4D sequences. A bit of caution here is that although this is fairly new, there's not much data as of now. There is dynamic nature of the mitral annular motion. Imaging planes are not very perpendicular. There is partial voluming averaging, and there is signal loss when there is extreme turbulence. So this has to be interpreted with caution and done with a little bit of experience. Moving on to the next facet of diastology is fibrosis. And we found that the CMR can produce a direct assessment of replacement and interstitial fibrosis. And the most important issue that I discussed for the cause of diastology is the extracellular matrix or extracellular volume. And the T1 images are very good in showing us that. Now, when you look at fibrosis, there can be both ischemic and non-ischemic, and the peculiar patterns with the non-ischemic and the ischemic help us zero down onto the etiology. And what is even more important, the very fact that there is fibrosis means your all-cause mortality, heart failure, hospital, and STD suddenly increase by triple-fold. We know that different diseases constitute diastolic heart failure, and we require multiple stains at the pathology lab. But in MR, we make use of a single stain, and that's called the T1 mapping, which looks at the exact molecular relaxivity of the individual myocardial cells and then maps it out depending on the kind of disease. So the highest T1s and the ECVs are with amyloid and acute MI, and the lower ones are the metaplasia, especially post-infarct. And this is a patient with a normal T1 map here around 925. Remember, this depends on the individual magnet and the reference values that you have constructed into it. And this is a patient with a high T1 suspected amyloid patient. Now, the ECV is got by a complex formula, but this is generally, you need to just have the hematocrit and do a T1 post-gadolinium. And this is the ECV that you get, a normal ECV, and there's a patient with the highest ECV. The highest ECVs are generally with patients with amyloid, especially TTR amyloid. And this is a patient, there's a paper looking at the relationship between focal and diffuse fibrosis. And what it showed is that the event-free survival is quite good if you have a T1 ECV, which is not very high, but in the fourth quartile, very high ECV, you can see how different the event survival curve is, and that can be seen also over here. So the ECV now has a bearing on cardiovascular mortality as well. Now, just like in echo, the GLS, which is defined as a change in the LV myocardial length between diastole and systole, is a very powerful diagnostic marker for the LV function and relaxation. And we can also get GLS on the MR with special software. And you can see the septum has an abnormally high GLS. Normally, the lower the GLS is, the better it is, but here it is quite high. And the same region also has a high T1, showing you that the GLS and T1 have a very close relationship. And if you look at this patient who progresses from mild to severe heart failure, you can clearly see here that the T1 values here are near normal. They keep increasing, and then they have a very high increase in patient with severe heart disease. And the gadolinium, again, is free of gadolinium in the mild, starts appearing in moderate, and then there's significant. So the gadolinium and the T1 sort of go hand in hand. Looking at tagging, or what we call feature tracking, again, a very important part of echo, where we look at both the circumferential, the longitudinal, and the radial. And these are pictures of radial strain, and these are pictures of longitudinal strain. And you can see where there is a high longitudinal strain here, the same place the radial strain is quite low. So very good correlation of the radial and the longitudinal strain on MR. We talked about LA volume, and as you know, MRI is much more accurate than the transthoracic for LA volume, and we have the normal reference values for MR as well. And this is the way you calculate it using a 4-chamber view here, having a longitudinal and transverse diameter and the 2-chamber view, and you get the LA volume. And then you can use it by forming an LA stack volume and also getting a 3D volume, which is very, very accurate. And what this also does is that the LA volume seems to have a direct measure with mortality. As you can see, when you have a normal LA volume, the hazard ratio is approaching unity. And while the LA volume starts going up to severe level, then it shows a higher mortality risk. Also, LA strain and function can be calculated. And the MESA study clearly showed that the larger the LA volume you have, and the more the chance of developing subsequent heart failure. Dr. Parashar showed us some very beautiful pictures of constriction, and I'm just showing you the same. And this is a very classical example of reversible diastolic heart failure. But what is important on MR is we can also show you the inflamed pericardium, which is a very good thing to show because these patients can be medically managed. Moving on to cardiomyopathies, and this is again familiar. Dr. Prabhu has shown you amyloidosis, and this is a very good city representation of an RCM. The characteristic scarring seen in amyloid, the bullseye appearance is very characteristic, and then you have a very large ECV. Yeah, just the last picture here. It's very good for management, and the T1 and ECV is also excellent. It can be also used in the iron evaluation, and you know that patients with iron also have diastolic heart failure. And of course, most importantly, in hypertrophic cardiomyopathy, the presence of scar puts them at a very, very high risk. And EMF, again, a very rare disease, and that is also seen. So essential to the appropriate care of diastolic heart failure is to look at cardiac morphology and function and to identify the pathologic and modifiable substrate. Thank you very much for your patience here.
Thank you, Dr. Christopher, for this very nice overview of cardiac MRI in diastolic dysfunction.